Hey everybody, I'm Maggie and we're on another episode of SRH Access Facebook Live. Today I'm here with our Chief of Staff Emeritus, Dr. Tony Herring, and we're so excited to have him back. We had him on a couple of weeks ago, so we really like him, obviously. So he's back with us today and we're really talking about what makes a teaching hospital, how Scottish Rite is a teaching hospital, and kind of all the details into that. So to kind of get us started, what is a teaching hospital?
Well, a teaching hospital is where people that are learning something in medicine go to be with patients and to see actual practice of medicine. And it starts usually with medical students. Medical students spend several years in classrooms, but then they spend another couple of years going to various parts of various hospitals where they, at first, they kind of stand in the background, then they begin to be able to do things, and they're always under supervision. And that's how they learn to become a doctor. Then further in training, people have to do residencies in whatever they're going to do, obstetrics, pediatrics. For us, it's children's orthopedics. And so when our residents are learning orthopedic surgery, they spend 6 months with us learning pediatric orthopedic surgery for children. And then following the residency, believe it or not, after 5 years of residency, you still have to do one more year to get a subspecialty. So if you're going to do sports, if you're going to do hand surgery, and for us, if you're going to do children's orthopedic surgery, then you do another year at that level where you've already been fully trained as an orthopedic surgeon. And so we have really people at all of those levels in our medical training. We also have nursing students and physical therapy students and all different disciplines of students that are learning, psychologists. So there's an awful lot of teaching going on in what's called a teaching hospital.
That's really cool. And we can kind of get into what that looks like here. But I know that you've really been a part of it here, like especially our fellowships from the start of it. So can you kind of give us a historical timeline of Scottish Rite Hospital being a teaching hospital?
Sure. And
what the fellowship and how that was developed?
And I think we have been a teaching hospital for the University of Texas Southwestern Med School for orthopedics ever since orthopedics started there. And now we have the orthopedic residents who come for 6 months at a time, and they're learning children's orthopedics. And then in about the early 80s, we started a fellowship program where fellows would come for a year to train in children's orthopedics. And they, now it's one of the really finest programs in the country. It's very competitive to get into, and we'll interview maybe up to 40 or 50 applicants from all over the United States and some from other countries to come and be a fellow with us for a year. And we really get extremely bright, fun people from all different walks of life and from all different training programs and the programs around the country, around Canada. And we've also had fellows we've trained from many other countries. And, many fellows have come from China in a little bit of a different training program, and from New Zealand and Ireland and really just about anywhere you can imagine.
Really
Spain,
cool.
lots of France. Really
so
lots
it really
of
extends
fellows.
the Scottish Rite Hospital family for sure, kind of all over the place.
And I think one thing that people unfamiliar with it may not know kind of how it impacts patient care. And the first thing I think patients need to understand is that we as the staff surgeons are responsible for everything that happens. And we control our operations, and an operation's a complicated thing. It's like building a building. Somebody's doing this, somebody's doing this, and we're always in complete control of what's being done. At times we may not be holding the knife, as you would say, but we're exactly sure of where it's going and what it's doing. And other times we can be more helpful to the case getting done by not actually being the person holding the knife. We can be the one that's making sure everything else is going okay in the room. But what is really good for patient care is the decision making. And children's orthopedics is complicated, and the children's problems are very often individual. You'll see a child that has something that no one else has, and you really want to find the best way possible to make them better. And as an individual, you may have a certain amount of experience, but you may not know some things. So every Monday night, we get together and we go over every significant case that's going to be done that week with all of our staff. And just this week, we showed a case of mine that Monday night that I'm going to do Tuesday morning. And one of my colleagues said, you know, why don't you think about doing such and such to the other hip? It really won't add anything negative to the case, but it'll add something very positive. And I was focusing on the other hip, and that allowed me to think, well, I really need to do that. And I analyzed what they said and thought that was a good idea. So the next morning I spoke to the parents and told them why we thought this was a better idea, and we went ahead and did that. Mm-hmm. And they say, well, you know, you're the chief. Can somebody tell you that what you're doing is not a good idea? And I said to the visitor, I said, I wouldn't hire anybody that would be afraid to tell me it wasn't the right idea. I want people to speak up and say, gee, I did that and it didn't work. And I read something in the literature that something else would work. And so that's the kind of interaction that makes it work.
What about, I mean, because you're talking, I know that these fellows are here and even residents and, you know, they're interacting even during a clinic visit.
Right.
So maybe for a parent and a patient, what could they expect when they're coming in for a visit? Who are these people that are coming to, to watch over my kid?
And this is another place that is really for benefit for the patient. Because let's say you're coming here for the first time, and either the resident or fellow or maybe the nurse practitioner will come in and take the history, the whole story, examine the patient, order some studies, maybe an x-ray.
Right.
And then they will come and tell me all about it. Then I will come in and see the patient as well. And by them seeing them first and me seeing them after hearing the whole story, I have a pretty good idea of what's going on that the trainee may not have thought of yet, or the x-ray hadn't come up yet, and then we see the x-ray and we go back in. And so they, while they're in the room, do certain things that drives the residents crazy. They'll say, you know, the doctor asked you when your shoulder started hurting, and you said it was 3 days ago. But do you remember 3 months ago it was hurting then? And then when you played basketball it was hurting? So I come back in and I get a new history. Say, well, you know, this really started 6 months ago. And you see some funny things like one time we had a patient that had this. She was like 15, but she had something that looked like it had happened to her a long time ago. And the resident asked him, well, what happened? Did you ever get injured when the baby was young or anything like that? And the parent said, no, nothing like that. Not any kind of a fall or anything, no. So I heard the story and I said, yeah, this had to be some sort of injury. So I come back in and I said, have you thought of anything, was there anything that could have happened? And they were kind of country people and said, oh, you know what, Henry, you remember when she was 18 months old and you ran over with the tractor? Oh. And you're thinking, oh my gosh, you forgot you ran over with the tractor?
Man.
So funny things happen like that. And the girl was fine. I mean, it wasn't like it was a disaster.
Yeah, so she was okay.
Yeah,
that's good. I know before you were kind of talking about our relationship with UT Southwestern, and that's kind of been a long-standing thing, especially with our residency. So kind of looking at the fellowship and how I know that one of the big things that our fellows do when they come here is research. I mean, that is a big, it's a component of their year while they're here. So could you kind of get into the relationship with UT Southwestern and maybe how they're collaborating with us for our research?
We do a lot of research. Our goal in research is to find better ways to manage problems and understand the problems better. So if we're doing a certain kind of operation, we've been doing it for a number of years, but sometimes it works really well, sometimes it doesn't. Well, we want to know why, and we want to pull all those cases and look at them, bring the patients back and ask them questions. And it is a wonderful spot for the residents and fellows to learn more, because when you dig really deeply into something like that, you learn a whole lot more about it.
Right.
And we also have an excellent team of research coordinators, so that we don't want to put a burden on the patients. We don't want to ask them too many questions or prolong their visits, but we are able to do it very efficiently, so that their participation we really appreciate. And I think a lot of patients and families won't really want to do that, to kind of give back and say, if we can help you by letting you check our blood counts or do genetic studies or things like that, then they're usually very willing to participate. And then what we come up with is presented at national meetings and published in the journals that go around the world. And, you know, we've come up with a lot of things that have changed medical practice all over the world.
Yeah.
And findings of things that people didn't know about before we really looked into it.
And what's cool is, and I know with, you know, as a teaching hospital and part of this fellowship is that these fellows get to be a part of that.
Sure.
You know, and so when they come in, I know they have different, you know, some might have, you know, a interest in spine, you know, although that they're being taught holistically with the whole pediatric orthopedics, but some might have something specific that they're interested in. So when it comes to research, how are they, can they pick, or how does that kind of determine what they're studying? Or
They, you know, when they first get here, we go through and present to them all the projects that are ongoing, and then various staff members say, and I've also thought about maybe looking into a club foot problem that's such and such. Anybody interested in looking into that? And they work for several, you know, a month or two, seeing cases that they see and seeing things that might interest them. And so it's a matter of them selecting something that they're interested in.
yeah,
And something that may have a relationship to what they're going to do in the future. They say they may know where they're going to be practicing, and certain problems exist there that they'd like to look into. So they participate a lot in deciding what areas to delve into.
that's great. And I know what a big part of what we are is, I mean, we wrote the textbook of pediatric orthopedics, I mean, literally. And so I know that our big thing is we're teaching the future of future doctors that are going to treat children of the future. So maybe let's get into this textbook. What is it? I mean, you're a big component of that. All of our doctors are big components. So.
The textbook was started by a man named Tajan, kind of a complicated name, and he died, and it was the textbook that was most widely used really around the world. And they contacted me and said, would you be willing to edit this textbook and have it written by your staff? And I agreed, and I came back and told my staff, and they told me they wanted to have me jump off the cliff because this is one of the 3 volumes of this textbook. So add these 3 together and you have 2,500 pages of textbook, and we had to rewrite the whole thing, and there were only 8 of us at that point. And everybody's saying, well, why are we doing this? Why are we doing this? Well, now we're redoing it again now for the 4th time. It's revised about every 5 years. And everywhere I go, people tell me how important this is to them. And I've been in Asia and Europe and South America, and it's the go-to, they call it the Bible of children's orthopedics, because it's the one that's the biggest. There's another book that's about half as big as this, that is also a good book, but this one's the one that you go to for the final answers. And we also make tapes in here, videos of cases and surgeries. And I've had people, you know, from places as far away as, you know, Bhutan and Azerbaijan, and they'll come and they say, oh, Dr. Herring, we put up your videos in the operating room while we're operating to see exactly how you do these surgeries.
Wow.
And so it really has a big impact, and it's one of the few books that's written only in one institution. It says on the front, Texas Scottish Rite Hospital. And most other big medical textbooks are written by people from a whole bunch of different institutions, and each one does one chapter. We do the whole thing here. We have one person that does the chapter on malignant tumors, which we don't do, and he's a professor in the Harvard program, and he's the only contributor that's not here.
Yeah. Wow, that's pretty incredible.
It's really
great
good
for our patients too,
It
to
has
know
been
that
good, yeah.
that expertise is.
And it's good for us. Like I'm right now in the middle of going through rewriting chapters, and I have to pull all the new literature in, and it's a great education for me.
Yeah.
It stimulates me to know exactly what's going on in the various areas.
Which is only going to help our patients even more.
That's right, exactly.
So I think it's time to take a little stroll down memory lane and get through some of these photos to kind of wrap things up, so we can kind of go through and you can kind of describe what's going on and maybe pinpoint some of familiar faces people might notice.
Walk over there. This is us, our teaching group, in 1979 when we had just come over to this hospital from a smaller building across the street. And This is me. I haven't changed a bit in this 30-something years.
Not at all.
Dr. Carroll was my predecessor as the chief here for 30 years about. Dr. Izaki became one of our staff. She was a resident at this time, and she became the first woman to be president of the American Academy of Hand Surgery, and has done a brilliant job. She's probably the best hand surgeon in the world for children. And others, this is one of our fellows then, another fellow then, and 3 residents, 2 physical therapists. That's the group that was there at that time.
Oh, we got another good one here.
Now this is one of our very early fellow groups. Dr. Winger was one of the staff with me. He was the first staff I hired, and he's gone on to head up the program in San Diego. Dr. Roach was the second staff I hired, and he went on to be chairman of the program in Salt Lake City. And these are 2 of the fellows at that time, Dr. Johnson and Dr. Birch, who went away to 2 different hospitals and worked for 2 years and then came back and joined our staff. And they're still on our staff now, many, many years later. And this is me and one of the residents, and this is probably early 80s. I think he was a resident in the 1980s.
And we still, this kind of, obviously the setup is a little bit more modern now, but
yeah, this is the old x-rays hanging on the wall.
We're still doing this today.
Yeah, we're still doing this. And the hospital was so smart to build the clinics where there's an inner area of the clinic where there's no patients. And then there's an outer area where the patients come and go through the doors. So in here you can talk about everything, get all ready to see the next patient, then go and see them. And it's an extremely efficient thing. This was a teaching session. I don't know when this was. This must have been like 1930. And these were nuns who I guess were training in nursing and had these incredible hats. And I bet this is about 32 or 33 when this was done. And
wow.
Our hospital's been around a long time. And one time in clinic I found out a family history where the grandfather had been treated here. And I asked the head of medical records to find the record. And it took her about an hour, and she came in and said, Dr. Herring, you can't believe this. I just couldn't find this. I finally found it. Said, he hadn't been seen here since 32. And they still had the chart.
We still have it.
We still have it. And this is very early on. In the, quote, the new hospital. The hospital was very new at this point. And smaller than it is now. It's been enlarged since then. And this is me looking at a child. And this was Dr. Winger, my associate at that time. And look at the bell bottoms.
Those
plaid bell
pants.
bottoms
plaid
back in the days. And Dr. Lawson was here before me and was really started our scoliosis clinic, and he's the one sitting at the view box. And that was making rounds at that time after seeing some patients in the clinic. That's again probably in the early 70s.
Wow.
And the old operating room. And they told me that they didn't have air conditioning in the 40s, and they would open the windows and hang wet sheets over the windows, and then when it got over 100 degrees in the operating room, they'd cancel the next case.
That's probably smart that they did that.
Not do that. And this is more modern. This is us now. They're doing some surgery with a scope inside the chest and watching it on the screen as they do things. And so they're just tiny incisions on the chest, and they put the instruments inside and can work on the vertebra from the front that way.
There's even more modern one.
Yeah, this is current. Wearing the high magnification glasses for doing spinal cord work. It's very delicate. Teaching, this is our teaching conference currently. This would be our Monday night conference where we're seeing all the cases for the week. And we'll have 20, 25 people there. Now we have a big staff. I have 18 full-time orthopedic surgeons now, and quite a large staff.
And this is where, residents and fellows are able, they do the presentation.
They do the presentations.
So they're talking about the various cases,
yes.
which is also good practice for them as they...
In the old days when the residents were terrified of the staff finding something wrong, we don't do that. We make people want to learn and enjoy exchanging ideas. And so the learning process is exciting. People enjoy it now and not threatened by it like they used to be.
Yeah, they're not scared. Let's see, I think we might have... Here's one of
This is our group about, this is...
probably a couple years ago.
A couple of years ago. And so that's the staff, the residents, and the fellows. And I'm holding up our book, I guess, to publicize it.
To publicize, yeah. I think this was just...
There's more recent, yeah. You can see how large our group is. I have trouble believing it's so large.
It's gotten so big.
Starting out with 2 people. It's when I started.
That's
so
awesome.
We have done some serious growing over all these years. And It's been such a fun place to work. I don't ever want to leave it. It's
Yeah.
the most happy place you could ever work, I think.
That's great. I think to, kind of wrap up with you, and I know that, I mean, you're a legend here. Everyone knows Dr. Herring, and you've been from the beginning with all of the teaching, especially with the fellowship. I mean, what do you see has been the biggest change or the biggest, what has evolved from the very first class of this fellowship all the way to now?
Well, I think the biggest non-change is that the patient always comes first. No matter how sophisticated you're getting,
Right.
that's your first obligation, is take really good care of your patients. But our impact now is really worldwide, and sometimes it's sort of frightening to think about it, but at every meeting, we're usually the leading group, having the most papers, and we know our textbook is the leading textbook in the world. And so it's a big responsibility. You really want to make sure you're getting it right before
Right.
you
You're
put
sharing
it.
it with the world.
That pushes our research, to make sure the research is pure, getting down to really valid answers.
That's awesome. Well, thank you so much for being
You're
here today.
welcome.
It's been great. So we'll be back
Give me-
next week, SRH Access, Facebook Live. Thanks so much.